All right, welcome back from lunch. We have a special guest, Dr. Roland Barrowman. You there, Roland?
Yes.
All right, excellent. Let me just do a quick introduction. If I may, Roland Barrowman is an Australian trained oral and maxillofacial surgeon, if I didn't screw that too badly. Roland completed his Bachelor of Dental Surgery at the University of Otago in New Zealand before relocating to Australia to complete his medical degree at the University of Melbourne. He was selected in the Victorian Oral and Maxillofacial Surgery Specialist Training Program in Melbourne and has worked in hospitals across Victoria. Roland is comprehensively trained in all aspects of the specialty and has advanced his skills with fellowship experience in complex facial injuries at the Royal Perth and Fiona Stanley Hospitals in Western Australia in 2016. He then relocated to the UK for further subspecialty fellowship training in head and neck oncology and reconstructive surgery at highly regarded units in Glasgow and Bristol before returning to Australia. He has also spent time in facial surgery units in the US, London, Singapore, Brazil, and Paris. Outside work, Roland enjoys being outdoors, traveling, experiencing different cultures and cuisine. Most of all, enjoy spending quality time with his wife and two daughters. Welcome, Roland.
Thank you.
Over to you.
Thanks, Kian, for that introduction. And thank you, Simon, for this opportunity. So today I'll be talking about orthognathic surgery. And as a bit of an outline, it's quite a broad topic. A very large topic, so we'll sort of be getting a bit of a flavour about the background, some of the common procedures and reasons why we need to do orthognathic surgery. I'd also like to share a few cases as well. And I'll be focusing the remainder of my talk about the surgical management of transverse maxillary deficiency and telengathic surgery for obstructive sleep apnea. So as we've been discussing with this group, has been very much about the growth modification and early intervention with treating dentofacial deformity. However, as we all know, as the patient gets a little bit older, we need to opt for other options, which can include orthodontic camouflage or orthognathic surgery in conjunction with orthodontic treatment. So in terms of treatment need, these are the patients with the skeletal discrepancies, which are severe enough. Just trying to get rid of this. Severe enough that neither orthodontic camouflage, growth modification would be able to provide the desired facial aesthetics and dental occlusal relationship and airway. And these are generally patients that we operate on when facial growth is essentially complete to allow the greatest post-treatment change. And of course, the patient has to have a desire to have orthognathic surgery in the first place. So let's see if I can get rid of this. I've got the screen issue.
It's looking fine. Everything okay?
I want to try and shrink down the panel on the side. Is there a way of doing that?
You mean on the panel with all the names of the panelists?
Yeah, it's quite large on my screen. So
you can, if you put your cursor on the very center where there's a double white line, you can drag it across.
Yeah, right at the border.
Yeah, it doesn't seem to be finding the cursor.
Right,
press on.
Of the black and white, I guess, with your... Might help. Looks okay from our end, but...
Okay. So in terms of the objectives of orthognathic surgery, basically we want to address function in terms of occlusal stability, as well as periodontal stability, and of course there's the issue of the airway as well, as we've been discussing a lot in this forum. And we also want to address the patient's aesthetic concerns, which is often their main concern. Orthognathic surgery is done with conjunction with an orthodontist oftentimes, and there needs to be decompensation of the occlusion. And this enables us to achieve a maximal amount of correction when we actually perform the orthognathic surgery. However, in selective cases that are more straightforward, a surgery first approach or surgery early on is possible, and this can have advantages. When we're thinking about orthognathic surgery, there are certain procedures that are considered very stable, and basically these maneuvers, they comply with the anatomy and they kind of make sense. So a maxilla going upwards, mandible forward, chin in any direction can be a very stable movement. However, when a mandible positioning further back or maxilla down, these movements can interfere with the airway and also the pterygomasseteric sling, and so they're considered less stable. So some of the common procedures that we have, these are the workhorse procedures, which include the Lefort-1 osteotomy. This is the maxillary osteotomy, and then we have in the mandible the bilateral sagittal split osteotomy and the genioplasty. Hugo Obergieser was the man who pioneered a lot of these modern approaches for orthognathic surgery, and he passed away recently in 2017. And I remember when I was a dental student, they had this book in the library on mandibular growth anomalies, and I was absolutely amazed by what could be achieved through orthognathic surgery and the procedures that was pioneered by Hugo Obergieser. And here we have a case illustration of a Lefort-1 osteotomy with the incision getting exposure to the anterior nasal spine and anterior maxillary wall. And we can see the infraorbital nerve on display there, and we can get very good access around the maxilla. Osteotomy is carried out in the anterior maxillary wall. We complete the natural nasal wall osteotomies with osteotomes, and we need to release the septum as well, and which can cause interference with repositioning of the maxilla. And here we can see the moment of down fracture of the Lefort-1, and we can see the nasal floor above us, and further back, a very important vessel, the descending palatine artery and the nerve. And most of the time we try to preserve this nerve when we do the Lefort-1 osteotomy. And having freed up the interferences and mobilized the maxilla, we are now able to reposition it in 3 dimensions. So commonly we'll be moving the maxilla forward or moving up and changing. We're also able to change the midlines. And here's an intraoperative photo showing a maxillary impaction case of 4 millimeters. And in this case, we're able to use a saw to remove a 4 millimeter portion of bone and reposition the maxilla superiorly. So the maxillary blood supply in a Lefort-1 osteotomy, it relies in fact from the soft tissues around the maxilla and the palate. And so that comes from the ascending pharyngeal artery, which is a branch of the external carotid, and the ascending palatine artery, which is a branch of the facial. As you can see, after the Lefort down fracture, the nasopalatine artery is sacrificed, and oftentimes the descending palatine arteries are sacrificed as well. However, we do try to preserve that when we perform maxillary osteotomy, because the more blood supply is better. We're now looking at the medial aspect of the mandible, or the lingual aspect, where the inferior alveolar nerve enters the mandibular canal. And this is how the medial border, the medial osteotomy is performed. And looking at the lateral aspect now with the osteotomy along the external oblique ridge up to approximately where the lower 6 is. Inferior border cut going through there. And once it's performed on both sides, we are now able to reposition the mandible in 3 dimensions, whether that's coming forward or correcting midlines or asymmetries. Some intraoperative photos here showing the osteotomy on the lateral aspect of the mandible to the inferior border, and the repositioning of the mandible with a 10mm advancement with plates and screws. And a post-operative view here with maxillary and mandibular advancement with a good soft tissue profile result. Now, the other procedure, of course, is the genioplasty, and this is a very versatile procedure that we use for both aesthetic reasons, for vertical reduction, for example, for excessive lower facial third, or correction of anterior-posterior or transverse issues. And it's also performed for functional reasons as well, to improve both lift competence and to normalize the soft tissue relationships around the teeth and provide stability. And of course, this is one of the procedures that can be used to improve airway in obstructive sleep apnea. As we all know, the genial tubercles here on the lingual aspect of the mandible is where the genioglossus and geniohyoid muscles attach. And so there's a possibility to advance those structures. Some intraoperative photos now with some of the modern plates that we use with a step. And this allows advancement of the genioplasty, and it's a very stable way of doing it. And using a different technique here, and with fixation and advancement of the chin in this case. Now, in the not too distant past, we used to do a lot of model surgery, especially for bimaxillary cases, and this was a particularly, we still need to do it, but it's quite a fiddly thing to do. And this shows the intermediate position that we need to bring the maxilla into with this would be for fabrication of an intermediate wafer. But luckily these days we're able to use virtual surgical planning, which is done with computer software, and we're able to customize plates and use cutting guides and wafers, and it's been a real game changer in terms of the ease of planning and both execution of the surgery. Piezo surgery is something that I use in my practice as well. It's as a morbidity reducing aid. It's certainly a lot safer to segmentalize around teeth using a piezo surgery as opposed to with a osteotome. So when we're considering some of the dental facial deformities, this is from Posnick, but there are certain growth patterns that we commonly seen as candidates for orthognathic surgery. And these include primary mandibular deficiencies. So these would be like the class 2 patient, small mandible, weak chin, perhaps with submental fillness. And they often present with a lower facial third deficiency and a convex facial profile. And the mandible is such that it gives the illusion that these patients have like a large nose. And then we have the maxillary deficiency with relative mandibular excess, and these are the typical class 3 patient with speech and chewing and swallowing issues. And they often can be the candidates that we see as we've been discussing with chronic obstructive nasal breathing, which is commonly seen with this growth pattern. And they'll have that characteristic sunken midface, flat nasal base, and so on. And then we have the long facial growth patterns, vertical maxillary excess, and mandibular deformity. And these will often present with a lower excessive anterior facial height in the lower third, with a gummy smile or anterior open bite. And a lot of this has to do with mouth breathing as well. And then we have the mandibular asymmetries, which can present with hemimandibular elongation or hemimandibular hyperplasia. and the short face growth patterns with maxillomandibular deficiency or with bimaxillary protrusion and dentofacial disharmony. So here's an example of a young lady with who's pre-surgery with a primary mandibular deficiency, class 2, very deep brachycephalic. And we can see that she has a diminished lower facial third. And with the advancement surgery, we have a much more pleasing aesthetic line and softening of the labiomental crease there with an increase in the lower facial third and a fairly stable result overall. Class 3 case, this young lady underwent a surgical maxillary expansion prior to bimaxillary surgery to correct her class 3 with a relatively deficient hypoplastic maxilla. And it's really nice to see these patients as when they come back to the office. Yeah, they sort of, after the surgery, they become more sort of confident, and yeah, this young lady had a good result. And just taking you through their virtual surgical planning now, you can see that she's had the expanded maxilla. If you look closely, you'll be able to see that she's had maxillary expansion, Lefort 1 previously. The planned position of the maxilla, bringing it forward 5 millimeters, and a very small mandibular setback to go with it. And we can also predict the soft tissue changes as well using the software. And we can see that she's had a good result from that. And another class 3 case, young lady, and we can see she's got the deep labiomental fold and a very long lower facial third. Computer planning, maxillary advancement. This is the intermediate wafer that is used. So maxilla first approach, mandible to fit. And it's very useful with the planning software. We can see where interferences are potentially going to be, and this can aid us during the actual surgery, especially where there are minor asymmetries. There tend to be interferences that need to be dealt with. And we plan for a small reduction, genioplasty advancement for her as well. And this was the final result there on the X-ray and the preoperative plan position. And you can see the changes in the soft tissue profile. And she was very satisfied with her result. This next case is a vertical maxillary excess. So this is the long face individual. She had a history of chronic obstruction and nasal breathing. You can see she was probably one of the most marked vertical maxillary excess cases I've treated. And we planned for a 8 millimeter impaction there. And we have to warn the patients beforehand that there can be some nasal changes in terms of nasal widening, and we try to minimize this with maneuvers on the piriform aperture, turbinoplasties intraoperatively, and septoplasty. But sometimes we may need to consider other options as well, such as alar wedge reduction, referral to peri, for example, to address any issues. And we can see that she's had a nice result there with good lengthening of the mandible, because with the impaction of the maxilla, what tends to happen is that we get a counterclockwise rotation of the mandible, which equates to a pretty significant advancement in the mandible, as you can see here. And we have a mandibular asymmetry case, class 3. Young lady here, and she's got a 4 to 5 millimeter midline shift to the left-hand side, which you can see most obviously on the PA radiograph of the skull. And we're able to get this result with correction of a midline, a mandibular midline, with maxillary advancement, and mandible to fit, and correction of their midlines.
It's quite amazing looking at the technology available with the surgical cut guides and the planning. We see how you guys can plan the movements and then build customize the cut plate so that you bolt it in place so that you cut along the dotted lines and then change over with the bolts so that you've got the movements predetermined and set. I can't imagine the older surgeons like Walford and Hernandez in the earlier days when they just did it by hand-eye coordination.
Yeah, we used to do that not too long ago, actually. So, the technology has exploded, like in terms of, just better understanding the applications and so forth. Yeah.
And that must reduce the predictability of the movements and the careful planning and the avoidance of all vital structures must reduce the risk level of relapse for the MMAs and make them more accessible for a broader range.
It's made it more predictable, and like in the old days, we had to, we're relying on seating of those intermediate splints. We're also trying to get a reference point, so we'll often use a K-wire, like right in the nasion area. So we don't need to do that anymore. With the plate, we can basically move the maxilla relative to itself after doing the osteotomy. So it's certainly simplified surgery a lot more. In terms of that time factor and predictability, stability, and so forth.
And then, Sandra, when we were chatting with Stanley Liu earlier this week, he mentioned that his preference now is to start with the dome, get the maxilla developed, and then move it as one piece. And again, that reduces the risk of the complications of the three-part, but allows him to do a much more aggressive MMA. Moving three parts and then worrying about the structures limits you a lot more.
Oh, absolutely.
I was talking to Dr. Perez Varela just yesterday, and the way it's done in Spain is they custom made the expander, and they let him know I'm gonna call. Ilan, I'm gonna call. Sorry about that. And Ilan, I'm in the phone. No, you can't talk to me right now. Sorry about that. There's a lab in Spain that custom makes the expander to the patient. So based on our prescription, we can actually custom make the expander and the screws.
Yes.
So it's not necessarily, something over the counter that we're going to adjust and just, solder it to bands in the teeth. It's especially designed for the patient. So the way Stanley does it, he actually does the dome going through the nose. So it's very minimal invasive because he doesn't even have to, cut inside the mouth. He was explaining that he goes in through the nose and he does all the cuts through the nose. So it's very, very fast.
The mini dome. Yeah.
The mini dome. Yeah. Yeah. And now with our expander that's custom made, it's just, and then going into Invisalign, it just becomes a procedure that's more gentle to the patient.
Absolutely.
And then after that, we set up the case, we get the expansion. Simon has designed a fantastic lower expander that actually adults can do very well with. That does, it's based on the contact resorption, not on teeth movement. So then you can set up the arches, and then they can actually feel comfortable going through a second procedure. Because back in the day, it was like having two Le Fort ones, one to expand and the other one to advance. The patient didn't want to go through two projects. So mini dome, or the Federico calls it samarpe, which is a surgically assisted micro implant.
Samarpe,
Yeah, the samarpe. They're simple in-office procedures. They're not as expensive, and they're not as they don't have the morbidity that a full effort could have. And then the patient can feel he's being prepared to the big surgery of advancement.
Sandra had
Interesting.
shared with me one of the videos of the procedure that Frederica had recorded, and if it's okay with her, I'll share it with the group as well.
It's in Spanish, but you can see it in real time. And you can see the custom-made expander too.
I would love to see that video, actually.
Yeah, so we'll share the link and have it downloadable for everyone.
Yeah, and Dr. Alfaro is perfectly fine with me sharing it.
Right.
Perry. Oh, your sound, Perry. Let me. Hello, Perry.
Can you hear me now?
Yep.
Yep. I've just got a few questions and a few comments. Great talk, Roland.
Thank you.
The first was with regards to the wafers you were using, because there are a number of sort of bone matrix preparations. There's some cadaver bony and cartilage preparations. I'm just wondering what you meant by that.
So, sorry, which one was this?
With the wafers, when you were acting, do you put anything between that, or did you just allow blood and fibrous tissue to?
Oh, okay. So it depends on the movement. Say, for example, maxilla coming down, there's obviously going to be a gap there. So that would require grafting. So there's different options for that. Oftentimes, we're able to take some of the mandible, sliver of the mandible, the outer cortex, and use that to interpose. But there's also products off the shelf which we can use as well. We commonly use that with genioplasty, and so that's replaced with like bone grafting technique, so like creeping substitution, and that can maintain that position where there is a gap. So I hope that answers your question.
Do you find any are better than the others? Do you prefer autologous
tissue, 100%. But there's other products on the market, made by various companies, like bone blocks. There's also in the US they use a lot of cadaveric bone. Yeah, it's only just starting to work its way into the Australian market, I think. There's like one supplier, I believe. And you probably know this as well for like, cartilage grafts and things. It's, a lot of cadaveric products are used overseas, and but perhaps not so much in Australia.
It's just coming, it's just becoming available now.
Yes, yeah.
Yeah. I just also wanted to make a mention, you showed an interesting case of a person with maxillary excess, and where you disimpacted the maxilla. And the maxilla looked lovely, but the nose looked worse.
Yes, it did.
And I think this just highlights the multidisciplinary approach that we should all be taking here. Because I'm looking mainly at the nose and seeing the super depression and the alar widening, and but I'm looking at the maxilla and thinking, oh, that looks really nice. So so that was just my comment.
You're absolutely right. I mean, some of the movements with orthognathic surgery, there are certain ramifications for moving a maxilla forward as well as moving it up. And in her case, it was probably the biggest impaction I've done in my career. It was about 8 millimeters. Look, in hindsight, maybe we could have gone for a softer impaction, but certainly we did have the consultation with the patient saying that this could be an issue with your nasal widening. And certainly in units that I've worked in the UK, there were surgeons who did, rhinoplasty as well, and they would do a secondary procedure such as an alar reduction. But you're right, though. Certainly, it's good to get an ENT opinion, especially with these sort of cases, to make sure that she's got like a good functional airway, and we can maintain good tongue posture for her as well, and jaw strength. Mm.
Yeah, I think that I would say do what you have to do, and an ENT rhinoplasty surgeon can mop up what needs to be done to the nose later. And the corollary to that is that I sometimes see patients with, say, a bit of rosacea on their nose, and the dermatologists just say to me, "Do what you have to do. I'll mop it all up once you're finished."
Right.
Occasionally when they're really bad, I insist on them getting some pre-treatment, and sometimes, especially with acne.
Yes.
But again, I think it's the knowledge now that we are collaborative, and it's multidisciplinary, that I think is the key question, or the key point there. The other thing I wanted to make a mention of was you mentioned in one of your slides there was hemimandibular disproportion, and yes. I like how you were looking at the mandible, yet we talk in ENT terms about hemifacial microsomia. So we're looking at it from another perspective, that we're looking at faces, looking at their asymmetry and saying your nose can never be completely straight or never be completely symmetrical because your face is asymmetrical. Mm. So you were looking at it mainly from what am I going to do?
That wasn't a hemifacial microsomia case. That was a mandible elongation, and that sort of had a twisting effect on the maxilla and also the nose.
Yeah.
But yeah, you're right. Yeah, sure. It's certainly worth having a wider perspective with looking at facial assessment.
And the other thing I wanted to mention was with the dome, what age are you actually doing that in? Because those upper incisors seem like they're getting really quite splayed.
Correct. Yeah, so these are in adult patients.
And do those teeth come back once they get orthodontics?
How do you mean?
When you were doing the dome and you were transversely widening their
yes.
Yeah. There was a big space between their upper incisors.
Yes, there is. And so what happens is that there's now a bridge of bone in between in the alveolar component. And there's a concept called regional acceleratory phenomenon. I'm not trying to bamboozle you, but basically, following surgery with the bone, there's kind of like a cytokine effect, cytokines that influence the ability to move teeth within the alveolar envelope, if that makes sense. And so the orthodontist can actually move the teeth into the space that's created. Yeah.
Okay.
So basically, yep.
Yeah, I was going to say the other thing that I thought was interesting is that in the paper they were talking about the internal nasal valve rather than the external nasal valve, and they're
newspaper.
And it's interesting because strictly speaking, as you had mentioned with spreader grafts, is that the internal nasal valve is much higher than the area that you're operating on.
Yes, but at the same time, I think what the Stan Liu group was getting at was that it's increasing the base of that triangle, and that would have a ramification with that internal nasal valve angle, which would be, it might improve from, say, 12 to 15 following an aggressive dome where there is a expansion of a good centimetre in between in the nasal floor.
And the other thing I wanted to mention was that I think they probably need to get a another acronym for MMA, because I keep on thinking of mixed martial arts, and you don't really want to have them conjoined as the likely outcome.
Yes, yes, perhaps that's a valid point. Yeah.
I just think of cage fighting, and
yes, I think if a patient was to Google MMA, that's probably what they would find out about.
Roland is first and foremost a trauma surgeon, aren't you, Roland?
Oh, yes.
Well, I must say that one of the worst injuries I've ever seen in MMA was a guy who was kneed to the face, and his entire nose got imploded between his eyes. And so I think that was a case of double MMA. I think he needed it both.
Indeed. You'll probably need to see both of us, right?
Exactly. But thank you.
All right, thanks, gents. We're a little bit over now, so let's just wrap up with a couple of last questions, I believe. If I'm Meadlehead, is, in your opinion, should we still be doing MAS? Reference to Meadle?
I'm just referring to doing a mandibular advancement splits, given the success of MMA now, and really, you know, whether we should be treating mild sleep apnea in younger patients, it seems almost pointless in the absence of comorbidities, you know. So, yeah, just because you know, use of an MAS in long term can lead to the headgear effect as well. So, yeah, just wondered what your opinion was on that.
Well, certainly, you know, it's the range of options would need to be discussed with the patient, you know, as part of the informed consent process, and ultimately it's up to the patient to decide. We can't really sort of recommend one thing over the other. I mean, obviously, if it came to my office, I would have a, you know, a sort of bias towards surgical treatment, but well, certainly it's not for everybody, and there would be patients who would certainly elect and prefer to have mandibular advancement splint therapy over having the thought of having jaw surgery. So yeah, it depends on the patient, I would have thought, and the discussion with them.
But in terms of long-term outcome, surely MMA would be a better choice, right?
Yes, potentially, yes, in select patients. Yeah, ideally what we would want to see is a permanent solution. But obviously, patients are more complex than that.
Sure.
There may be weight issues and so on that need to be addressed concurrently. So, you know, the contemporary approach for obstructive sleep apnea patients, as we all know, is a multidisciplinary one. So that's important to bear in mind.
Cool. Thank you.
All right, and the
Thanks,
last
Nathan.
question before we go to a break, I think it was Nathan, you had a question about what software is used for the planning?
The one I use is TrueMatch. Yeah, that's one of the ones that I use. That's the name of it. But yeah, it's a very, very elegant software. I don't sort of do all the little movements myself, but the way it works is we sit down and have a planning session. And so we have someone who contacts us. We set up it's kind of like a Zoom chat, and we go through the planning together. Yeah. So there's different softwares available. There must be so many on the market by now.
All right, terrific. Well, thank you so much, Roland, for a terrific presentation. I'm sure
Thank you, Ken.
Rejoin later for Q&A, perhaps at the end of Perry's presentation. So let's take a break, guys. We've had a long session. We're going to take Simon. You think 10 minutes, or we'll be 5 minutes behind schedule if we take a 10-minute, or if we take a 5 minutes, we'll get started with Perry at 1:45. What is it? 2:45 as originally scheduled. You guys want a 10-minute or a 5-minute break, Simon? Simon's having a break right now. So on that note, thanks again, Roland, and we'll come back. Let's take a 10-minute break. We'll come back,
10 minutes.
Come back at 2:50 for Dr. Perry Burston. Looking forward to it. All right, thanks everyone.
Thank you.